Hello, my name is Dr. James Lehmann, and I'll be narrating a surgery I performed on a 51-year-old keratoconich patient last week. We were doing a deep anterior lamellar keratoplasty, and as you can see here, I marked the central cornea with a blunt tree fine, and now we're performing a peritomy and wet field cautery. The next step involves creating a scleral groove superiorly, from which we will proceed with a scleral tunnel up into the clear cornea. The plane of this dissection is as posterior as one can get and enter the anterior chamber, just superior to Descemet's membrane and the endothelium. I'm extending the incision laterally and now making an inferior paracentesis through which I'll inject an air bubble. I'm closing it with a suture so that the air bubble can stay tight, as we need to have high pressure during the lamellar dissection to ensure that we don't rupture Descemet's membrane. Here I've inserted the Morlet spatula, and we're doing blunt dissection of the posterior lamella of the cornea. You can tell you're in the right plane when you can easily dissect tissue forward and left to right without much effort. Here we're extending the dissection inferiorly to the area that was previously delineated with the blunt tree fine. Now here to the side. And now we're removing the air bubble and marking the cornea with an RK marker for our cardinal sutures. Here I'm injecting Helon into that space we just created, and it's pushing backwards the Descemet's membrane and endothelium so that we can perform trephination. We know we're in the right plane when there's some egress of the viscoelastic material, as we just noticed right there. Now removal of the recipient button is performed using corneal scleral scissors, and care is taken not to rupture that very fragile posterior aspect of the stroma, Descemet's membrane and endothelium. Here we're drawing the bed so that we can see how deep the dissection was and how even it was, and you can see in this inferior nasal aspect that there's some residual posterior stroma that I just dissected again with the Morlet spatula, and then I'm going to trim here with Van Ness scissors, careful not to damage that posterior area. Now we're proceeding with donor preparation, which consists of dyeing Descemet's membrane. Removing the dye right there and touching there. We would never do that in a normal transplant. Now we score Descemet's membrane, and the next step is going to be removing it, because we don't want to place that into the recipient bed. So there's Descemet's membrane being removed, and then we punched it at 8.5 millimeters, the same diameter as the recipient bed. We're placing the donor button down into the stromal bed now, and we're going to suture it in with the 4 cardinal sutures, placing one at a time and then tying them. We do a 50% bite through the donor and a 90% bite through the recipient. Here we're lining up the inferior suture, the most important one, to ensure good alignment. Tying that, and now the remaining sutures. We tie them very tight, as we want good apposition at the wound edge. And again, a 50% bite through the donor and a 90% through the recipient. Now we're drawing the epithelium, and you can see the nice diamond shape there. It looks like a square, which suggests that they have equal tension and depth. That's very important. Now we're going to place 4 additional cardinal sutures that can be all placed and then tied, which saves time. Now, what are the advantages of a DALK over a penetrating keratoplasty? Well, I think there's 3 main advantages. The first one is that you really can't have endothelial rejection because the patient has his own endothelium. Additionally, if there was to be trauma to the eye, it's much less likely to cause a rupture of into the anterior chamber. And then the third one would be overall comfort level and recovery after surgery is much faster. Now I'm placing a 16 bite running suture with kind of anti-torque sutures, basically 2 in between each of the 8 sutures that have already been placed. You may ask why we're placing 24 sutures, and the reason for that is we want good wound apposition so that there's no induced astigmatism or problems with epithelialization from bulging of the wound edge. We're done here. Just going to tie that last suture and bury the knot. You can see, checking the integrity of the globe. Kind of a final shot of the eye. We're going to inject a little bit of subconj kinolog to help with postoperative inflammation. I want to thank you for your time. Thanks and have a good day.